for coming and welcome to the Rapid Process Improvement Workshop, Improving the OT Pathway Report Out. So Improving the OT Pathway, the report out will cover the scope of the project, the background, the current state mapping, the targets that we set out to achieve, what we have achieved, newspaper of future requirements, the lessons learned and our thank yous. Improving the patient journey by simplifying handoffs and transitions to address was the scope of the project. There was long waiting times, there was complicated patient journeys, there was multiple handoffs, and there was lack of data sharing, and there was little standard practice.
We started our conversation sort of back end of last summer from I suppose a fairly informal discussion between myself and Doreen. So I'm Janet from Professional Lead for Company Partnership, and a discussion between myself and Doreen and Amanda Evans and with Click, where we started talking about whether we could be doing something along these lines, which then culminated in a county-wide OT half-day meeting in October to start to put a bit more sort of meat on the bones of it, really. So from that half-day, we really identified what's working well and what's working less well, and gave us some priorities that we wanted to work on. Now, these at that time included the fact that we have across organisations sort of multiple roles, multiple services, with sort of the leadership and specialisms impact, the implications of all that. That's actually probably one that we haven't really covered actually, so but that was one of the initial focuses. The other focuses which we then have gone on to was the very much issues around hands-off and transfers of care, and some issues around moving and handling, paperwork and joint assessment and with learning and procedures around that. And also communication between our different organisations, in that it probably didn't flow as well as it could do. So what we then did from the 17th of October, we did a whole load of process mapping and patient journey mapping, and a substantial amount of post-it notes have been used in this time, which you might see a little bit of in the later on in the presentation. So we completed that, and then we went into a 2-day mapping in January, and we had a really quite intense 2 days where we mapped our processes really quite closely. And which was very reassuring in that we were all following the same process, but it also did highlight quite a few things. So that's really where we come to today. So that is in preparation for going into this rapid process improvement workshop. And what we said at that point in January what we want to achieve. So what we started on Tuesday with was a plan to start to develop a draft compact or agreement for how we're going to work together, and how we're going to embed this within our 4 organisations. Also identify a shared vision of how we can sort of learn together and learn and train and sort of develop our relationships together as well, really. Also, the other target was around developing a standard for appropriate transfers of care. So that's something we really wanted to work on, and develop a process for creating a register of equipment reviews. So that was the 4th target. And finally, we're developing a register and directory of OT contacts and a process for keeping it up to date. And just to say that we've got those 5 targets, but the reality is that they all actually mix and merge to a certain extent. They all link together. So that was our broad targets, and so we did now just like to give some feedback on what we've done in order to achieve those targets now.
So our first aim was to organise the compact, which is a cross-organisational agreement based around behaviours. So we formulated this from collected and compared organisational values and philosophies. And then we wrote and agreed our shared aims and principles using the driver diagram and A3 planning sheets, and they're displayed on the wall for you to look at. We discussed gaining our organisation's buy-in and drafted an email for sponsors to send to the occupational therapy groups, and there's a draft of that on the wall as well. And we planned a series of workshops to consult and engage staff following this.
Obviously the draft compact, how we achieved that was we've done a shared vision statement for OTs in Cumbria, which is around behaviours, and we've done 7 key principles for the compact. Obviously I won't read the statement out, but it's on the wall over there. But the 7 key principles that we've agreed are: number 1, the service user and carer are at the centre of our care and support. We will take responsibility for our actions and behaviours. We will work well to achieve quality and safe care, which is occupational focused. We will communicate in a clear and constructive way. We will maintain healthy relationships with every person individually, in teams and services, in terms of value, trust and respect. We will be innovative, resourceful and determined, and we will show a commitment to shared organisational learning to ensure continual professional development and improved outcomes for service delivery. And also what we have done, which again is in more detail on the wall, is we did a consultation and development plan including workshops, and there's a lot more detail on what they are to include, so you're welcome to have a look over there. Thank you.
Yes, we looked at shared learning, so we discussed and developed the shared aim for learning and training using brainstorming and a driver diagram. This helped us gather our thoughts and look at what we needed to achieve. We then decided a shared learning and training compact, which was incorporated into the overall compact, which ensured shared learning is incorporated into organisational behaviours. We undertook a mapping of our current learning and training opportunities to identify gaps and potential opportunities for the future. We researched and mapped our communication networks in relation to shared learning, which identified the key players. And we designed a survey to be sent out to all occupational therapy staff and cascaded the links to leads within the organisations. This was in order to explore demand and need. We also scoped a profession-specific conference for Cumbria OTs as an opportunity for the future.
So we quickly realised that there was a shared vision for learning together across all 4 of the organisations involved. So to enable the dissemination of the information to all staff, we developed a communication tree, which is on the wall there, which has key contacts for the 4 organisations involved. We did a scoping exercise to capture the current informal and formal learning that's available across the 4 organisations, which again is on the wall there. We've created an electronic survey using SurveyMonkey to identify training needs, and we've sent that to the key contacts and asked them to disseminate that out to all occupational therapists within the 4 organisations. And we've also scoped a Cumbria profession-specific occupational therapy conference for later in the year, and we've put together a list of ideas of what we would like to be included within that.
So we spent quite a long time debating and discussing all the issues that had come out of the mapping event. And we felt that whilst there was really good patient care going on, the patient journey was actually limited, and that was because when it came to the point of handoff between services, it wasn't very good practice, or it just didn't happen at all. So we agreed a shared understanding of what a good transfer would actually look like, and within that we looked at roles and responsibilities and boundaries of care. We reviewed the existing liaison document, which had been in place since 2010, was never really fully agreed by anybody, but everybody was working to it and was quite outdated. And it wasn't really representative of the new service anyway. After that we had quite a lot of ideas which we struggled to pull together into anything coherent. So we used driver diagrams and pulled it all together into what we needed to do next, and then we looked at the PDSA of the existing mapping to see if any of our new ideas would improve service.
The document that we came up with, which was the main focus of our work in this particular area, was a cross-organisational working agreement, and there's a copy of it up there. With all the discussion, I think it's quite amazing that we managed to be so concise and managed to get it down to 3 sides. But that's what we did. It basically includes, it sets out to clarify the roles and responsibilities of each service. It looks at, as you can see, there's a flow chart there. It looks to establish when referrals should occur within the OT process. So we took the OT process and we looked at what point handoffs, referrals should occur, what the opportunities were, and there's quite a clear flow diagram there on how best to achieve that, to provide a little bit of consistency and guidance. The third part of it really was looking at the information that we give from one OT to another when a transfer is made, and making sure, always bearing in mind that our objective is to to enhance the experience for the patient and provide a safe and coordinated service across organisational boundaries for OT. It's really important that the information from one therapist is passed on in a coherent way to another, so they get all the information they require and are able to make use of that in the most effective way. So we developed some guidelines, like an OT checklist, at the bottom there, and that would accompany each referral with copies of any documentation that's necessary. So in some ways it's quite simple, but there was a lot of discussion in order to get to that point. And along the way, some quite significant changes and some clarification of our roles and boundaries within individual services. That's something that requires a bit further testing, I think, in due course. In addition to roles and responsibilities and transfer guidelines, we did also look at things like equipment provision and minor adaptations. Just to clarify a few issues around that, everything's contained within the one document.
And this was a lady who had a life-limiting neurological disorder, and we found that if we'd applied the checklist and the joint working protocols, it would actually have reduced the number of OTs involved with the lady. It would have targeted the right person with the right skills at the right time for her, and reduced her confusion as to who was doing what and how and when. It also meant that some of the risks that she was placed under would have been removed because the right processes would have been in place, maintenance and insurance and equipment, and the right assessments would have been in place. And I think the starkest bit was the timely provision of equipment. As we'd mapped it originally, it took from June to November for us to get a piece of equipment. Using the new process, it could have happened between June and July.
We looked at the issues concerning equipment reviews, and this was equipment that has been provided for manual handling purposes or equipment that needs to be maintained under lower and fewer regulations. But first of all, we just wanted to establish that we had a clear understanding of what we actually wanted to achieve. And the 3 points that we came up with were that equipment needed to be fit for purpose, that it continued to meet the person and carer's needs, and that it was still in use and being used appropriately. So in order to come to those 3 key points, we used one of the A3 improvement sheets, really just to kind of consolidate and organise our views and thoughts on those issues. Another one of the issues was around the palliative care teams, who don't generally discharge back to the community, because obviously they will keep that case open for longer, or for the length of the case that it needs to be open for. And similar issues existed in children's services where cases weren't being transferred or didn't go through transition into adults, into the social care community teams. So really what we did identify after we've got all those key points was there was a real issue with existing databases, got lots of information across lots of different areas. So we identified that we need to do quite a big piece of data cleansing, but we don't want to reinvent the wheel and create a new register to capture all this. We wanted to use existing resources that were available and existing databases as well. So we identified that we can use a range of databases. We've got the IES system, we've got Asset Hound, which is part of the stores management process, which tracks assets, and also we've got databases in health, CPFT in the palliative care teams, and also in children's services. Okay, so as I say, we identified what those databases were and how we could access those, and we came up with a plan for launching on a 6-monthly basis a register once we've got all those all the data cleansed up to date, and we've set ourselves a plan to achieving that by June. Okay, and the other thing that we needed to be very clear about was making staff understand not only the 3 key points earlier around being fit for purpose and meeting people's needs and still being in use, but also that staff understood that it wasn't just a case of trying to create more work for people by making them do reviews, but the reason behind that was that it needed to be clear that their responsibilities under the Manual Handling Operations Act and the Health and Safety at Work Act were there to protect themselves, but also the service users as well. And we've agreed as a result of that to trial process in the Eden area, with it being a smaller area, just in terms of kind of cleansing up the data, and also looking forward how we're going to issue the list in the future.
So aim 5 was to look at communications, and we were asked to develop a communication system and protocol. So over the past 3 days we've scoped our current communication network, we've discussed a framework for a communication network and identified the need for a service directory, and we've agreed that the information could be shared via Campbell's as we should have access to the Campbell's network, and Kate Vernon will support with that. So we've achieved clarity about scope of the network and how to share information and access it, and we've agreed to update this on a quarterly basis via our team leads and our own service.
As a team, I think we've achieved 80% of what we set out to. We've learned lots from each other, we've learned lots about different services, we've learned things that other people could help and support us with, and I think that sets us off on the journey of more joint working, more knowledge. What we've also done is put plans in place for 30 days, 60 days and 90 days, but a lot of these things are going to take much longer to embed and unpick, because as we said before, the joint working protocol has been in discussion for many, many years, and 5 of us sat round the table and actually hammered out what we thought was a workable document, which is no mean feat.
So with regard to the compact, we need the sponsors to email and back in regarding the compact endorsement, and I want to do that as soon as possible. We need to cascade via the team leaders in the organisations by April or May, and the cross-organisational workshops to be led by the process owners in June, with feedback by the appreciative inquiry in July. In relation to the learning together, the survey has been carried out and has been sent to the leads today to cascade to all staff members, collating feedback by Mariana and Karen, and then in April, and then learning and the training plan. We need to link to our LD colleagues in the various organisations. The process owners will do that, and we will do that by May. And then Janet is going to lead as a link for the conference, which will be November.
In order to roll that out, we really need the sponsors to assist us with that, and to get back in an endorsement from all the many teams out there. So we want to work with the sponsors to do that during March. There needs to be a rollout and cascade of agreements by the teams and at team forums by the process owners during April, and we plan to pilot the use of the new working agreement with 10 patients per organisation, led by the team leads during May. For the equipment we use, there's going to be a meeting with the Eden Valley Hospice OTs about the palliative care OTs there in March. There needs to be a data cleanse to produce a correct register. That's going to be done in June, and rollout of the processing guidance to be done during July.
So a template's been designed, it's going to be sent out today, and it's going to go to the team leads who are going to collate that, and then after that it will be uploaded onto Campbell's. And then we're reviewed quarterly through the team leads and kept up to date, which will be the main challenge, keeping things up to date, particularly as our services morph and change over the coming months and years.
So from the lessons learned, really, what we have learned is that 5 organisations working together is very powerful. That improved working together is the way forward. But breaking down barriers, it comes through trusts, which is about relationships. And there's been lots of breadth and knowledge applied over the last 3 days. This is just the start. It takes time and effort to effect change in the workforce and make it meaningful and lasting. Together we can achieve significant change. 3 days, it would appear, is not enough. The scope of the involvement in the improvement process is crucial, really, and obviously perhaps there should have been some other non-staff members, non-OT staff, members who we would have preferred to have connected with, but we weren't able to for various reasons. But it is obviously, we have been a bit OT-centric purposefully, but we also need to link to our other colleagues as well. And essentially, the click facilitation has been essential and is essential to continue to proceed with this.
Just say all the thank yous really. First of all to what we're describing as a home team, which is all the occupational therapists in the 4 organisations, which is a very wide group. And I certainly know that there's quite a significant number of them, although they might not be here today, have been involved in a lot of the process mapping but throughout the county, so which has been really exciting. Actually, it's been a fantastic sort of thing to go through, process to go through. Also, we haven't got here today Wendy Harrison, who's the clinical manager for occupational therapy services in Morecambe Bay. She was here over yesterday. She wasn't able to be here today, but she's obviously been central as well to everything that we have achieved over the last 3 days. Also, our sponsors, so Amanda from Adult Social Care, also Sarah Monroe, John Howarth and Helen May. So the sponsor involvement and support is absolutely crucial. We can't possibly do this without it. There's a lot of the things that we have agreed today that we really need to have backing from the wider organisation, and certainly we see this as a first step. So we need their backing for future steps as we go forward. Also, a very big thank you to Gemma, who has from Click, who has been invaluable in the last few days for doing lots of typing up, photocopying, more photocopying, and generally really supporting us in what we've been doing. So thank you very much, Gemma. I'd also very much like to say thank you to Zena Sells, who's one of the Children's Services OTs, who was here yesterday, who was able to give us some valuable input yesterday. Shauna from Adult Social Care, who was here the last couple of days as well, and Pauline Carlisle from Cumberland Partnership, who was here yesterday, and also Maggie, who was here yesterday as well. But finally, as Doreen's already said, a big thank you to Click, because without Rachel and Karen's support, this would not have happened. We have achieved absolutely gobsmacking amount of work in 3 days. We have achieved more in 3 days than we have in years, and it's by having Karen and Rachel really facilitating us and keeping us on track. So thank you very much for that.